Hello and welcome to another Macular and Me session with the Macular Society. This is the working age focus session, so we're going to be talking all things macular disease and the aspects of macular disease that affect working age people. So sort of macular dystrophies and technology and all that sort of stuff. I'm going to be talking with Annegret Dahlmann-Noor today around MMD, so myopic macular disease. So Annegret, welcome. How are you? You okay?
Thank you. Yes, thank you very much, Colin. I'm fine. Thank you.
Brilliant. Okay, well, we'll come back to you in a wee second, just after I've introduced Sarah Clinton. So hi, Sarah. She's our patient information manager from the Macular Society. How are you today?
I'm good, yes. Thank you. How are you?
Jolly good. So Sarah is going to help me with some questions at the end of Annegret's presentation. Anyway, that's enough waffle from me. Annegret, thanks very much for joining us today. If you'd like to give your presentation, then we can ask you some questions at the end, if that's all right.
Thank you, Colin. I'm just going to share my screen. Is this sharing? Can you see?
Yes, it's sharing.
Thank you. So first, thank you very much for inviting me to engage with you and talk today about myopic macular degeneration. And it seemed to me that the burning question that you wanted to ask is there anything new? And if so, what are the news? I am actually a children's eye doctor, a pediatric ophthalmologist. I work at Moorfields Eye Hospital in London, and I also hold an honorary clinical associate professorship with University College London. So I've got a larger than most doctors' research portfolio, which I utilize a lot to look into mechanisms driving myopia in children and what we can do to slow it down. In terms of disclosures, there are a few because I am the chief investigator or principal investigator for some commercial trials of interventions that slow down myopia progression, we hope, in children. And when you have that role, you then get invited into advisory boards or education material preparing boards. So I've done that for a few companies, and I've also helped with focus groups with parents and children. So what I thought we should cover today are really the basics with an outlook on research at the end. And the reason is that Colin kindly forwarded some questions to me, and I thought my answers to those questions would really only make sense after we have gone back to basics and talked about what MMD is, what happens to the eye, to the different layers at the back of the eye, why it's not the same in everybody, why people think it is becoming increasingly important, and what treatments there are already for some forms of MMD, and why slowing myopia progression might actually link into this topic as well. So the outlook on research will come right at the end, and then come your questions. In terms of the background, why is myopic macular degeneration or MMD important? To those listening and watching, it is crystal clear why it is very important. But to people who are funding healthcare and research projects, it's not necessarily very familiar. They will be familiar with age-related macular degeneration, but they might not be aware of MMD, and particularly they are not aware that it's something that hits people at a much younger age. So us on this call, we know that MMD is a major cause of sight impairment and blindness in people with high myopia, so more than 6 diopters, or pathological myopia, particularly in those aged 29 to 64 years. I'm not saying that those people are more important, but the importance there for funders, for people with deep pockets, is that these are people of working age. I'm in that age group. Many people on the call are in this age group. So we need to be able to earn a living, have the satisfaction of being independent, having a life that we can pursue, raise our families, and all of that. When you have MMD and it affects your vision, that is taken away from you. So it affects your quality of life, it affects your ability to earn a living, and then society needs to look after you. So I am going around trying to convince people that this is not only a problem, but actually an increasingly common problem. And that is my little crusade at the moment, to demonstrate that more and more people of adult age are affected. And I am bringing in other people because I am a pediatric ophthalmologist, but I will tell you a little bit later about how far I've got with this. There are figures from other European countries which support our impression that it is becoming more frequent. For example, in the Netherlands, they have done very good epidemiological studies about myopia in children, but also in adults over the past few years. And they found that within the myopic community, if you want, there is a prevalence of 25.9% of MMD in high myopes. So that is quite a significant number, because usually people say, so just as a rule of thumb of all myopes, 20% will develop high myopia. And then you're saying here that a quarter of those are going to develop macular degeneration. So that adds up really to a percentage of the population. And a similar number comes from a study in France, which again was, this one was hospital-based or eye clinic-based, but it was done in several centers across France. And they found that within their patient population of people with high myopia, 0.5% had macular complications. But if they had very high myopia of more than 10, it went up to 4.27%. So the huge difference between the Dutch numbers and the French numbers is probably because they looked at different populations. Not all high myopes or very high myopes end up in eye clinics. So you will always have a sort of skewed picture when you compare that with population-based studies. And in terms of the impact on vision, there are also pretty robust international estimates that we can draw on. One figure is, again, from France, at 60 years old or over, the prevalence of blindness or vision impairment in high myopia is nearly 10%, and in very high myopia, nearly 26%. And because this is, as we know, a global problem, because in East Asian countries, nearly all young people have myopia. So they have got enormous numbers of high myopes as well. There have been calculations that back in 2015, an estimated 10 million people worldwide had sight impairment from MMD. And of these, 3.3 million were blind. So I just repeat that. In 2015, 10 million people worldwide had MMD-related sight impairment, and 3.3 million were blind. Now, if we don't get a handle on this increase in myopia around the globe, then that number will go up. And by 2050, we are looking at 5 times as many sight-impaired people. 55.7 million people worldwide are expected to be sight-impaired because of MMD. And 18.5 million will be blind. And those are absolutely staggering numbers. And they are usually the type of figures that make people take notice. That's why this type of study is very important. Then I would like to cover the different forms of myopic macular degeneration. And I apologize that this slide is just jargon, right? It's just full of big words, but I have got some pictures on the next slides so I can explain what they mean. So there are 5 forms, if you want. They are myopic chorioretinal atrophy. That is where the back of the eye layers sort of shrivel and become atrophic. Then there is the neovascular form, where you have got new blood vessels sprouting under the central part of the retina, under the macula, and leaking fluid or causing hemorrhages. Then you have got something called traction maculopathy, and traction means something is pulling. And I've got some nice pictures to show you what is pulling on what. Then there is a relatively new condition on the list called dome-shaped macula, and that is something that we even see in young people and adolescents, and that can be linked to irreversible damage to the macula later on. And last on the list is something called lacquer cracks, and you might have heard of those when you were in clinic. So again, there are little gaps in the layer at the back of the eye in Bruch's membrane, which then allows blood vessels to grow through. And then sometimes they just disappear spontaneously, leaving behind a little scar. But sometimes they also cause inflammation. And that inflammation can affect the retina, and which then in turn affects vision. So going through them again in order with some pictures now. The first one was myopic chorioretinal atrophy. And that is what I think most people get. When they have high myopia, the eye becomes longer, the tissues at the back become progressively thinner, and eventually the whole process hits the retina and it becomes thinner and stops working. So on the diagram on the left, you can see the illustration of the layers at the back of the eye. So the innermost is the retina. This is the yellow line here, the yellow band. And the dimple in the center is the fovea. That is the area, the central area of the macula. So the retina is the layer with the photoreceptors, which change the light signals to electrical signals, and they then travel to the brain via the optic nerve. Underneath the retina is a vascular layer, a blood vessel layer called the choroid. And that layer is phenomenally important, both in myopia in children and in MMD. So this is like a sponge. It's a layer of blood vessels that bring oxygen and nutrients both to the outer part of the retina, which is lying on top, and to the white coat of the eye, which is the sclera, which is the layer underneath. The sclera is the white coat that holds the eyeball together. So when you look in the mirror, the white part of the eye that you can see is the sclera. It goes all the way around to the back of the eye, and it holds the eye together. The more myopic you become, the longer the eyeball becomes, and everything becomes more stretched. And the sclera in particular becomes thinner and thinner. And that is a mechanical problem, because if the sclera becomes thinner, then suddenly there can be outpouchings at the back. That's called a staphyloma. And that is one of the factors that can make MMD go worse. The other layers are also affected. So we know that as myopia increases, the choroid becomes thinner. And I've just said that the choroid brings blood supply, oxygen and nutrients to the layers at the back of the eye, right? So less blood supply means your poor retina doesn't get enough energy, doesn't get enough of anything. And that is why it doesn't work so well and why it starts to become atrophic. Plus being stretched from the axial length or the length of the eyeball increasing. And we can actually see at least the retina and the choroid pretty well on our scans. You may have had an optical coherence tomography or OCT scan at your optometrist or at the hospital. I've put a picture of that on the right-hand side of this slide. This is just the back of the eye. So it's this part around the fovea or macula, turned by 90 degrees to the right. So we have got the dimple, which is the fovea in the center. And then the grayish layers are the different layers of the retina. This very bright white band underneath is Bruch's membrane, which sort of separates the retina and the underlying vascular layer. And then this spongy layer underneath is the choroid. So you can see there are some very dark spaces in there. Those are the blood vessels. The choroid has got very thin blood vessels where it's closest to Bruch's membrane, and then they become progressively thicker as you move further back. We can't visualize the sclera, but on this picture here, the blue line at the bottom shows the boundary between the choroid and the sclera. And all these vertical arrows, vertical yellow arrows on the scan, are points where people have taken measurements to see how thick the choroid is. So the red one is just in the center of the fovea, and then they have measured every ½ millimeter out to the side. So we can do this measurement technique to check how thick the choroid is, which reflects how bad the myopia is. So it's something that we can quantify and follow up over time. And we know that as time passes, the choroid becomes thinner. So it is a marker of things not going very well. Once this process has been grumbling on for a few years, the appearance of the back of the eye changes quite dramatically. So our standard pictures of the back of the eye, the standard color photos, show the optic nerve. This is this pinkish disc on one side of the picture, and the blood vessels that it brings to the inside of the retina. So this is a fairly typical arrangement, but normally the back of the eye has got just a homogeneous orange glow. But when you are myopic, then the color starts to change because the layers become thin and more transparent. So you see more of the white sclera, if you want, shining through. So it goes from this nice orangey color to something more yellowish and then something whitish when the layers have become so thin, the light just goes straight through. And the chorioretinal atrophy, that's the first type of MMD, can be either diffuse or patchy. So the picture on the left shows a diffuse form. So you see this large area that has become more orangey than it used to be. And further out, you see this tiger-like pattern that's called tessellated fundus or tigroid fundus. What you see there are the choroid vessels shining through the retina because the retina is becoming thin. The other form is patchy. So this is the picture in the center. And there you see that it's not homogeneous, or it's not a broad patch around the macula. It is more sort of white patches that go round it, where you see the white sclera shining through. But overall, the retina has become very thin, and in many places, the choroid has become very thin. And on the right-hand side, you've got the third form, which is the one where vision is badly affected. Then that is where it affects the macula. So that is macular atrophy. At that stage, there isn't much that can be done about it, quite honestly, because the choroid has gone, or has become very thin, I should say. The retina has become very thin and has stopped working. And the cells that should recognize light signals and change them into electrical signals have suffered irreversible damage. So that's myopic chorioretinal atrophy. It's usually a pretty slow process, but because it starts with a mechanical problem and we can't address the underlying issues, there is at the moment no treatment for this. The second type is the more dramatic one. That's the myopic macular neovascularization. So that's our equivalent, if you want, of wet AMD, age-related macular degeneration. If you look at the diagram here first, so that's again the side image flipped round by 90 degrees. You have got here as a pink bar or beige colored bar, the choroid, which is our blood vessel layer. And then above that, they have labeled it as retinal pigment epithelium for the lilac or violet layer. And there is our violet line underneath. That's Bruch's membrane. That's what keeps our retina safe, if you want. And then on top of that, we have got the different layers of the retina. So the choroid has got lots of blood vessels. That's its job, right? And sometimes because of the stretches in myopia, the Bruch's membrane can develop gaps. And then these blood vessels can start sprouting little branches, and they will go through Bruch's membrane and start to build a little tuft of blood vessels underneath the retina. They then leak fluid or can cause hemorrhages, and our photoreceptors, the retinal cells, really don't like that. They don't like getting wet, and they certainly don't like sitting in a pool of blood. So they die, they stop working if that unfavorable environment lasts for too long. And the picture on the left, I just stuck in because it illustrates so beautifully where this happens in the eye. So you've got your clear window, the cornea at the front, you have got your optic nerve at the back, the central part of the retina, the macula right in the center, somewhere near the optic nerve. And then in the little cutout, you can see how the abnormal blood vessels go from the choroid through a gap in Bruch's membrane into the layer under the retina. And then sometimes they don't stop there, they just go right into the retina as well. So what does that look like when you come to the eye clinic? On the left, there is again our color fundus photo, and it has again this sort of thin retina appearance, this tigroid or tessellated pattern. But where the macula is, there are two sort of very dark dots, which might be indicating that there is some blood either pooling there or blood vessels building up there. And then we can take photos in black and white and we can zoom in on the blood vessels. But really what shows it best is, again, our OCT scan. So on the left-hand side of the picture, in the bottom panel, you have got one of these abnormal blood vessel membranes that have pushed through Bruch's membrane and is sitting under the retina, distorting everything. And then you see that there is a dark space on top of that vascular membrane. That is where it's leaking fluid. And similar pictures on the right. So you see a big, fat, dark colored blood vessel going through Bruch's membrane, and then the tuft of vessels sitting underneath. And the same in the bottom panel as well. So that is what your eye doctor and your optometrist are looking out for when you have an OCT scan. The third type on the list was myopic traction maculopathy. So traction means pulling. So what is pulling? Now inside the eye, we've got this jelly, the vitreous. And when we are very young, the jelly is really a jelly, and it's attached to the retina all the way around at the front of the eye and all the way around the optic nerve head at the back. And as we get older, the jelly becomes more liquid. So at some stage, it changes. And as it becomes more liquid, the liquid wants to get out of the jelly pocket. So at some stage, it squirts out. It's still all inside the eye. But the liquid comes out, the remaining jelly collapses, and that is when you have a pulling effect. So that is when then the remaining jelly is pulling on the retina and can cause little tears. But in most people, it doesn't cause any complications. In most people, it just comes clean off and you've got a bit of jelly lying in the back of the eye. You might have a week of flashing lights and then you might need notice some more floaters, but that's it, end of story. But in some unlucky people, there are more adhesions between the retina and the vitreous. And the vitreous is pulling away, pulling the retina towards the center. And in some people, that causes a retinal detachment. So the whole retina is giving way and comes towards the inside of the eye. But in some people, the retina then starts to fragment. It sort of starts to unzip between the different layers of the retina. So if you look on the picture here on the left, you can see this very fine line, which might well be a bit of vitreous that is attached to the retina, so it's pulling it forward. And then the other thing you might think is that this curvature of the eye is much steeper than it was on the previous pictures. And the reason is that this picture is from a staphyloma. So that is one of these outpouchings at the back of the eye that happen because the sclera has become so thin. So you have the staphyloma pulling back, the vitreous pulling forward, and the poor old retina is trying to please both. But what has happened is that the retina has split. So part of it has moved inwards and the rest is still hanging attached to Bruch's membrane. And that's obviously not very good for the functioning of the eye either. One particular form that can result from this is a lamellar hole or a macular hole. So instead of having our dimple at the back of the eye, where the photoreceptor layer becomes sort of thinner and forms the fovea, there can be a hole there and people lose their central vision. So that is shown on the picture on the right. That is myopic traction maculopathy. I already mentioned dome-shaped macula as something new on the block. That is where you have got the opposite movement. So everything is pushed, the macula is slightly pushed inwards towards the vitreous, and it doesn't like that either. So in that case, there is usually some thickening of the layers underneath, some thickening of the retina, and you get this bulge. And if that persists for too long, that can also cause problems. And lastly, you get the lacquer cracks, which are also gaps in Bruch's membrane, some new blood vessels sprouting through, and usually they just disappear on their own, leaving these little black dots as scars, or sometimes little whitish grayish scars. And if that is associated with inflammation, it can also cause problems with the retina. One problem with research and talking to each other is for us that there are these different types and different stages, and it's easy to just say, oh, this patient has MMD, but it's much more difficult to get a handle on what happens over long periods of time. So there are two classifications that people now use to describe better from one healthcare professional to another what the eye looked like at a given moment in time, and then to track over several years whether there are changes and what the changes are. So this meta-PM classification is, I think, the most widely used. Lots of myopia researchers use that, and that has 4 categories, or 5 if you include category 0, which is no macular lesion. I've left out pictures for those ones we've already talked about. So there are only 2 pictures on this slide. The tessellated fundus at the top, that's where the retina starts to become thin and have this tigroid or tiger-like appearance. I see that in children and teenagers, but usually I don't see anything worse than that in that age group. Then category 2 is our diffuse chorioretinal atrophy, category 3, the patchy chorioretinal atrophy, and category 4, the macular atrophy. And the other things that we've talked about, the lacquer cracks, the choroidal neovascularization, the new blood vessels, and the Fuchs spot, which is on the picture on the right, a little black area that is a leftover from new blood vessels that have gone away again. They are called plus signs in this classification. So you can have the main changes of the choroid and retina plus these localized lesions. And the second classification worth going through quickly is one that describes the degree of atrophy, so that's where things shrivel up, the degree of traction, and the degree of abnormal blood vessels. And then within each of these 3 categories, it goes from 0 to 4 or 5, and then you can detail exactly what the findings are, and then you can see whether over time things are getting worse. Then the next question from a research and a patient follow-up point of view is, do these categories happen in sequence? Like, do I start off with a tessellated fundus and then I go for my atrophic macula or the choroidal neovascularization? And it's not that easy. So it's not linear, it's not sequential. You might start out with a tessellated fundus, the tigroid pattern, because you're a high myope. Then you may develop a staphyloma, the outpouching, but not everybody does that. Not everybody gets that. You may get diffuse atrophy. Your Bruch's membrane may crack or not. You may get new blood vessels and then develop patchy atrophy. And you can end up with macular atrophy or not, but by very different routes. And that is part of the reason why it is so hard to really see whether any treatment that we want to offer helps. Because unless we focus on just one of these blocks, it's very difficult to establish a chain of causality, if you want. You know, what have you really achieved? And is it plausible to say that it's because of your treatment? That takes me neatly to the next bit, treatments. And as you know, I don't have much to present on this one, right? So that's about what I can say as an apology. So the best treatment is available for myopic macular neovascularization. So you've got new blood vessels that have taken advantage of that gap in Bruch's membrane, and they sprout through and they kill your macula by leaking fluid and by causing hemorrhages. So if you manage to get rid of those abnormal blood vessels quickly, then you would hope that you can rescue your macula. And because usually the situation is localized, it's not as dire as in age-related macular degeneration, where this Brooks membrane degeneration happens over a much wider area. People with myopia usually have a better outcome and a better prognosis when they have treatment for abnormal new vessels. The natural progression of this is, I found one study where they looked at people who presented with new myopic macular neovascularization and looked at their visual acuity. And 70% of eyes in that study still had vision of 660 or better. 660 is the top letter on your chart at the optometrist or in the eye clinic. Without any treatment, 3 years later, 55% of eyes could still see the top letter or further down the chart. So it had gone down from 70% to 55%. But 10 years after the start of the study, that number had gone down to 4%. So from this you can see that it is progressive and it does get worse over time, but it tends to do so pretty slowly. But if you start when you're 50, then even to say, oh, it's not so bad, you will lose your vision over the next 10 years is horrible, right? So you might already start with not very good vision, and then you might lose your central vision completely. And it's not a great consolation to say that it may go slowly if you're lucky. So learning from the age-related macular degeneration, which is also a choroidal neovascular process, people then said, why don't we use the same treatments? And I've only put the ones on the slide that are being used at the moment. So first, what's not on the slide is the photodynamic therapy, which is not used in the UK anymore. We have now the intravitreal injections, an illustration of which is on the right-hand side of the slide, where we use mainly ranibizumab or aflibercept. They are substances that inhibit the growth of new blood vessels. So they bind to certain receptors that make abnormal vessels shrivel away. And because in myopic MMD with new vessels, there is this phase where the photoreceptors are still alive, they're just unhappy. If you get this treatment quickly enough, your vision should improve again. The big pivotal trial for ranibizumab was the Radiance trial, and the outcome for that was visual acuity. And in these vision-orientated trials, you measure how many letters people can read on the chart. So it's not our Snellen or Logma, it's letters that get progressively smaller. And if you can read further and you gain more letters, that's an improvement. So in the Radiance trial, over 12 months from the first injection, people improved by about 14 letters. And with the second drug, the aflibercept, the MIRROR trial showed a gain of 13.5 letters over 48 weeks. I'm sorry, something is cut off by the picture, I think. So there was a gain of 13 to 14 letters over a year, which is really quite substantial. The other interesting thing is that the average number of injections that people needed over that year was 3. So it's different from age-related macular degeneration, where people have a loading regime and then they have to come to the eye clinic for a very long period of time to have OCTs, to have their vision checked, and to have sort of top-ups of their anti-VEGF injections. So for myopes, the landscape when you have new blood vessels isn't quite so dire. The other form of MMD for which there is some treatment is the traction maculopathy, because that's a mechanical problem, right? So you've got traction from the vitreous, and that is something that you can relieve by vitreoretinal surgery. So depending on what exactly you have in terms of traction, maybe an epiretinal membrane, maybe a macular hole, those are things that can be tackled with vitreoretinal surgery. And then there is the hope that doing that will also improve your vision, although it doesn't always work that way. Then I wanted to briefly touch on treatments that I am interested in slowing myopia progression. The main reason is that progression doesn't necessarily stop at the end of childhood. So when I see families in my clinic and we start something, they always ask, how many years is this for? You know, do we stop when my child is 12 or 15 or 18? And all I can say is that I don't know. We will just measure the progression every 6 months. We measure the axial length every 6 months. If it is stable for a year, then we can maybe discuss whether we can reduce or stop the treatment, particularly if by that time the young person is 15 years old or older. But we know that particularly those who continue their education, who continue studying for A levels, then go to uni, and then, God forbid, become computer programmers or something. So if they continue to strain their eyes a lot, there are some in whom progression doesn't stop. So they tend to have high myopia, but by that stage, so -6 or more, they have an axial length of 26, 27, 28 millimeters, and it might slow down, but it doesn't necessarily stop. So there are some very few people who still have progression, even in adulthood. And one of the questions for us is, should we treat them? Should we treat them with the same things that we use in the children? And frankly, we don't have anything else, right? So we can only offer them what we have in children. And yes, it still works a little bit at their age, just as it works a little bit in the children. So slowing myopia progression is also something that is becoming more relevant to adults with high myopia. That takes us back to one of my favorite slides about why does myopic macular degeneration and other complications happen. And if you look on the left, it says an eyeball less than 26 millimeters long has got a risk of 3.8% of developing sight impairment over lifetime. In people who are fortunate enough not to be myopic at all, the eyeball is usually about 24 millimeters long. That's average. So 26 is the point where you go from moderate myopia to high myopia. So that's pretty equivalent to about -6 diopters. So if you go to that point, your lifetime risk of sight impairment is 3.8%. If it goes more and longer than 26 millimeters, the risk goes up to 25%. If your axial length is over 30 centimeters, your lifetime risk of sight impairment is 90%. So that is why in children, at least, we try, and don't always succeed, I have to say, to keep the axial length at less than 26. But I don't like telling families that. Some of my colleagues say, you know, we do everything not to cross that line. But unfortunately, we don't have anything to stop myopia. So I think if you say that, you're setting yourself up for failure, right? Because they might be 7 years old, they might have 15 years of progression ahead of them, and it might just not be achievable with the treatments that we have at the moment. So I say we all do the best we can and don't spend sleepless nights, because we have done the best we can. And the chart on the right shows how the risk of sight impairment increases over your lifetime. So from age 40 to age just under 80. This is from a population-based study in the Netherlands. And so on one side, on one axis here, you've got the age, and on the other one, the risk of sight impairment. And in the left-hand side of the chart, it's about the axial length, the length of the eyeball. So if you have a very long eyeball, 30 millimeters or more long, you can see that the curve is the steepest. So if you get to this group of high myopia or extreme myopia, your risk of sight impairment goes up. And again, I like that chart because I can show it to people who don't understand really what I'm talking about, because they only have low myopia and they just don't get what the problem is. This is the problem. This picture is from 2015, I think, and it absolutely struck me. So this is from Singapore or Taiwan. And what's wrong with this picture is that they all wear glasses for myopia, right? This is a group of, 18, 19-year-old boys, and every single one of them is wearing glasses for myopia. I think there is one face somewhere in the background, this guy here, maybe is not wearing glasses, but everybody else has myopia. So statistically, we are talking more than 90% of young boys in East Asian countries, and in European countries, we are heading for 50% for young adults having myopia. And if we then say a fifth of those will develop high myopia, that's 10%. That's 10% of the population. So there is definitely something major wrong. And that is something, as I said already, that we see all over the world. So in all countries in Asia, North America, Europe, and also South America, the numbers of myopic people is going up. In the UK, there has been a nice study in Northern Ireland, actually the nicest study, which found that the number of myopic children had doubled over 50 years. So over two generations, if you want, it went up from 10% to 25% of 15 to 16-year-olds. So what can we do about myopia progression? And again, I put this slide in because it's something that optometrists and doctors like. We like to be structured. And this paper is from 2021, and the biggest brains in myopia management sat together to make a summary of the literature and the clinical trials and come out with recommendations. And you see that there are the pharmacological ones, that's low concentration atropine, that's eye drops to slow down myopia progression. You've got optical interventions, so there are special types of glasses and contact lenses that you can purchase now. And then the green box is the environment, because we know that the light and the lighting has got something to do with myopia in children. So for young children who don't have myopia yet, it is helpful to send them outside for an hour and a half or 2 hours a day, because the bright light that you only get outdoors acts like a braking mechanism for the growth of the eye. And we think that the reason is that there is some dopamine release. That's a neurotransmitter, a chemical in the retina, that when the bright light hits the retina, it releases some dopamine, and that slows down the eye growth. And there's also increasing evidence that the lighting indoors matters. And I've gone around some schools in Bedford with somebody with the UK Health Security Agency who is very interested in this topic. And we measured the light in the classrooms. And in one school, the lighting inside the classrooms didn't even reach recommended levels for buildings, leave alone schools, even when we turned the lights on. And there is, again, from China, increasing evidence that if you spend your day in a dimly lit room, you're more vulnerable to develop myopia and for it to get worse. The questions that Colin forwarded to me were about red light. So this is so new, it's not even on the previous slide, right? The previous paper, the slide before, was from 2021. But there has been this new treatment modality that has come in since then, red light treatment. And I put in here the graph that shows what a super dramatic effect this red light had on axial growth over 12 months. So this was studied in several clinical trials in China. You have got on the x-axis the timeline, so 12 months. On the y-axis, the change in axial length. In our control group, the eyes grew longer and longer and longer. They increased by about 0.35 millimeters over 12 months. In the group of children that were given a special red light, which was a laser light to use for 3 minutes, twice a day, on 5 days of the week, the slope is a lot less steep. It actually reversed a little bit at the beginning. And then the eyes continued to elongate, but much more slowly. And 1 year after starting the treatment, there was a difference of 1/4 millimeter between the two groups. And that is about the strongest effect we have seen with any treatment. So although it didn't stop it, it has got a very dramatic effect on progression. So the 2 years results showed a similar effect. That's on the right-hand side of the graph. Again, the effect continued, although a little bit less dramatic, into the second year of treatment as well. So we were all really, really keen to get our hands on the machine, on the laser machine. And now it has also arrived on the UK market, and you can buy it for or subscribe to it to a very, very large amount of money. But the other thing that's happened in the meantime is that there have been very serious safety concerns. One case report has been published in an American journal of ophthalmology about a child in China. And what happened there, I've put the OCT pictures in this presentation. You see that Bruch's membrane that we said is separating our retina and our choroid has got these dark dots here and there, and they shouldn't be there. So it looked like there was damage to Bruch's membrane and also the one layer of the retina, where you see a lot of mitochondria. They're special parts of photoreceptors that respond a lot to red light. So that area also looked damaged. So they stopped the treatment, obviously. The vision had reduced. The vision was affected, which is like our mega disaster, right? Because children have perfect vision. The last thing we want to do with a myopia treatment is to give them poor central vision. So that really threw a spanner in the works. And the company is saying that it wasn't even one of their devices. It was some sort of copycat device. And maybe the family used it for too long, not just for 3 minutes, twice a day. And there's a huge debate as to whether it is safe or not. And particularly from North America, there are now several papers that say this is not safe. We really need to look at in more detail at the safety of the red light. And maybe it's a bad idea to use laser. So that takes me to just one brief slide about what we are working on. We're using a different type of light source to generate the red light. And I have teamed up with Professor Glenn Jeffrey at the Institute of Ophthalmology in London, who has been working on red light for decades. And he has got experience with red light in bees and mice and humans, which he calls aged humans, because he thought the most important application might be age-related macular degeneration. And then I came with my papers about children with myopia. So we are trying to develop something safe based on red light for children with myopia. And we have got all the technology to build something and to monitor the choroid and to monitor the safety of the retina. So what we're doing at the moment is, or have been doing for the past 12 months, is apply for funding. And so far we haven't been successful. So we have done little proof of concept studies with adults. And we have got some funding to do a proof of concept study with children. So that is set up at the moment and hopefully will start later this year. But that is like the preliminary work that would then take us to a clinical trial. So setting up these research projects is very long-winded. You need to show it's safe in a small number, then in a slightly bigger number of people, and then you can apply for more funding for a bigger, so more participants and longer study, where you can then look at the impact that this treatment might have on the condition you're interested in. The questions that Colin forwarded me, there were just 3, so they're on these 3 slides. There is a trial going on in Japan with low-level repeated red light therapy. So that's this laser treatment for patients with pathological myopia. Do you know anything about this trial? And if so, what does it entail? How is it going? I don't know, I'm afraid. I have seen papers coming out from China and Japan that reported how the choroid is becoming thinner the more myopic you are. So the next step really was logically to use the red light because it improves blood flow in the choroid. It's thickening up your choroid, and maybe that has a good effect for your photoreceptors. I'm mostly interested in the sclera and slowing progression, but the red light will also improve the blood flow in the choroid, which will benefit the retina above. And it also has a beneficial effect on the health of the photoreceptors themselves. So if your photoreceptors are in a precarious position, it's plausible, I would say, that the red light keeps the retina going for longer. So this is not a cure, but it might be something that would help us keep the retina going. But I can't find details about a specific trial going on in Japan. Then somebody said, we have watched a video with Professor Glenn Jeffrey about the red light therapy. What are the differences, if any, between these therapies? So the difference is mainly the light source. Laser has got one wavelength. It's very narrowly focused. It's very bundled. And even if you tune the energy down, it's much more focused than any other light source. That is why we use it in surgery, for example, particularly inside the eye. Prof. Jeffrey uses different light sources. So they are LED lights, which you have right, left, and center. And there, the other problem that you then encounter is that you need to be sure that the red light that they send out has the wavelength that you're interested in at the energy level that you think is needed. So there are so many red lights that you can buy at eBay that it's impossible to say whether they have got any beneficial effect or not. And there is not one that has gone through the whole process to be certified as a medical device. So that is what we would like to do. Now, we're not saying this is groundbreaking new research for a Nobel Prize, but it would be one product where we know that it's of the right quality to actually have an effect. Whereas at the moment, the problem is you can buy red light devices and they might do what you want them to do, but then they might not. The Veleda light therapy is something related, but there people are asked to come to an optometrist who has a machine. So you can't just have your 3 minutes of red light at home. You need to go and have it there on site. It's a subscription model. They use, I think, 3 different wavelengths because they have got some science behind it, looking at the effect of different wavelengths of different parts of the cells. And altogether, the evidence that it does anything for ARMD, age-related macular degeneration, is quite limited. And for myopic macular degeneration, I think it's even more limited, not to say non-existent. That is why it's used, as your member said here, off-label. So it has been licensed for one indication, age-related macular degeneration, but optometrists also sell it or sell subscriptions for another condition, saying, it might work. I don't know. If you want to put your money there, let's try. And if you're not short of money, then there's nothing wrong with that. But if you are short of money, then I would be really careful with putting my pennies there. And the reason is that this is why I wanted to give this whole talk about what MMD is. It's not the same as ARMD, right? So you might have a stage where no treatment can make things better. So these red light treatments, I think, will show to be useful for people who are in the earlier stages, where the cells are under attack and suffering a bit, and you can make them work better for longer. But once you're past that stage, I don't think red light will do anything. But until we have done clinical trials, we don't know. So I would be cautious about anybody selling you a treatment for which you have to pay a fee. Lastly, would you consider including adults in the low-level red laser or red light? We don't do laser. We do not do laser. Low-level repeated red light therapy trial you're looking to start in the UK. I would love to. Logistically, we need to do things differently for children and adults. So it would need to be a different trial. When you set up a research project as a trial, you need to consider your participants, the intervention, the comparator, and the outcomes. So participants would be adults with MMD. That's not too bad yet, I would think, because you don't want to give it to people who have new vessels, because we don't know whether the red light might actually activate these vascular cells and make that worse, right? So we would be very cautious with what type of MMD we want to include. And my gut feeling would be that we want people who still have a reasonable amount of vision and where the retina is still reasonably healthy, and then see whether that can rescue those cells. So that would be the first parameter for the participants. The intervention, yes, we could give them low-level red light. That's not an issue. The comparator will be the next huge question. So if you sign up to a trial, would you be happy to be in the control arm where you don't get a working treatment, right? I think people wouldn't. And that they would just go to eBay and get something from there. And then we would have the problem that's called contamination. So that's where your control group is also using some sort of treatment, but are not telling you. We could, of course, use one eye. So you use the red light on one eye and not the other eye. And then we compare the two eyes. But I, as a participant, I would still be desperately unhappy, right? I would want to take my chances and I would use the red light on both eyes, quite honestly. So there are some big ethical questions, and we would need people like you to tell us how to do such a trial. And we would probably want to team up with clever people who design trials where the ethics are an issue and see what we could do so we don't have a control group. So for example, some people could start the treatment at one time point and the others would start at 6 months later. So everybody gets the treatment, but we could use the first 6 months to see what happens with and without treatment. So that would need some consideration. And then outcomes, that is the real problem with MMD. So in children, we can get our readout, if you want, at 6 or 12 months. There the question is, does the eye get longer or not? And how much longer does it get with and without treatment? So that's done and dusted in 12 months. With MMD, the outcome should probably be vision, because that is what we are trying to rescue, right? And looking at the numbers that we had earlier on in the slides, it usually progresses slowly. So will we find a funder that would be happy for us to continue the follow-up for 3 years, 5 years? Nobody will fund 10 years, right? So we would need to find a parameter that changes somewhere between 1 and 3 years of follow-up in a sufficient number of people to then say, oh, it's not just by chance, it's because of the treatment that we are trying. So in principle, yes, is the answer to your question. But I think we would need to spend some time together, right? So with patients, with not patients, people who have it, right? I'm a myope. I might be getting this at some stage. So speak to people who have the condition and speak to scientists to agree what we can achieve, you know, what we would like to do scientifically, but what is pragmatic, and then apply for funding so that we can get a research team together to actually run the study. And I think that's it for me, from me. So I was going to say thank you at this stage and bring Colin and his team back in. Thank you.
Annegret, that was brilliant. Really interesting, and at a level that even I can understand. So that you know, and I'm not a bear of much brain, so it's brilliant. Thanks very much. Really good talk. So Sarah, have we got any other questions that haven't been covered in Annegret's excellent talk?
I think most of the questions have been covered. A lot of the questions did involve red light therapy.
Yeah.
Do you have one question about if there's any benefit that's been shown by taking supplements for myopic macular degeneration? I know that there's supplement use for AMD and some evidence for that, whether anything was looked into for MMD.
Not to my knowledge. And the supplement trials, interestingly, they were phenomenal. They had so many participants over so many years because they knew that the problem was the slow progression of ARMD, right? But they really took the bullet and followed up hundreds of people over many, many years. And I don't see that anybody would repeat that sort of study ever. But that was done with age-related macular degeneration, which of course is many times more common than MMD, than myopic maculopathy. So it would be difficult to find enough people who have MMD to do the same. And because in MMD, you don't have the same problem with the buildup of this drusen material, I'm not quite sure whether supplements would make a difference, hand on heart, right? But if I had MMD, then I would probably want to try anything that is available that I can buy at Boots and it doesn't break the bank, right? So supplements, I think, do have a place, but in most people, just eating your normal healthy diet with some colorful food actually saturates all those cells, and taking supplements doesn't make any difference. The other thing is probably anti-inflammatories, right? Lots of these supplements also have anti-inflammatory properties, and people with arthritis or joint pain find them really helpful. And we know that in aging in the eye, inflammation also plays a role. And we have had in our slides today that in some types of MMD, there is also inflammation. So I think when you look at it just from a broader point of view, then probably supplements don't do any harm, and they might make a little contribution to keeping your eyes going for longer.
Thank you.
Brilliant.
Yes, I think that, yeah, no, those are all the questions that were emailed in.
Fantastic. Well, that's great. That's good. That means Annegret covered them all. That's good. So, well, in that case, Annegret, I'd just like to thank you for joining us today. It's been very interesting, brilliant talk. I'm really pleased that you agreed to come along, and we'll be back next month for another webinar. This one is likely to be on technology. That's what I'm trying to organise. We'll catch you on the next one. Thanks very much for joining us today.